Thank you very much. So I won't dwell too much on this topic, well, this slide just here, but I just want to highlight a couple of things. Osteoporosis and osteoarthritis are clearly aligned with advancing age. They're diseases that, as we age, the risk for these increase. So that's why I fit quite nicely into here and not the youngies. So thanks for coming. Can you do I just change the slides here? I haven't got a clicker. Yeah. So I'll just start while we're getting there. I'm actually feeling a bit privileged to follow Helen on from her presentation because she so eloquently described what the social gradient of health is. She really knows her stuff, which is fantastic. So she's given you a really good overview of what that actually is. I was just going to briefly touch on this model. This is from Dahlgren and Whitehead. It's also commonly referred to as a social rainbow. This gives us a bit of an idea of the population being in the middle, and they're actually surrounded by these different levels, overarching factors here: individual, social, infrastructure and policy. And all of these things impact on the individual or the population at the centre. This model doesn't really give us such a good idea of the interaction and the complexity of all these factors, but it does give us a bit of a really basic foundation for understanding. What this shows us is that social stratification does engender different exposure to health outcomes, disease vulnerability, material resources that can actually have a protective effect on our health outcomes. And also these factors all influence our health literacy or our understanding and access to information regarding health. Next slide, please. Thank you. So again, Helen beautifully spoke to this. So just briefly, we can see a social gradient of health in many diseases. We see it in respiratory disorders, we see it breast cancer, liver disease, accidents there. We see it around the world. So this social gradient of health goes from the top to the bottom of the socioeconomic spectrum. It's a global phenomenon. It affects low-income countries, but also middle and high-income countries. So we're actually not protected against this inequity. Next one, thanks. So just briefly, these two diseases, as I said, they're related to age. Osteoarthritis, it's a disease of the whole joint. It's characterised by the painful swollen joints and loss of function, and you can see a person up the top there. There's no cure for it. Public health expenditure is quite high, $4 billion annually. That's quite a lot out of the health system and also out of people's pockets too. And the biggest expenditure is due to pain relief and joint replacement surgery for end-stage disease. The other disease, next slide please, is osteoporosis. This is also a musculoskeletal disease. It's a disease of the bone. Results in a weakening of the bone matrix. So on the top left there, you can see a normal bone, and then you can see the osteoporotic bone, which is very porous, and a degradation of that bone matrix. A lot of people have it aged 50 years and over, and the public health expenditure for this a couple of years ago was $2.75 billion annually. Again, big expenditure on the health system. So whilst we see a social gradient of health in many diseases, there's not that much evidence before our work to show that it also exists in musculoskeletal disorders. So I want to show you how we've actually harnessed big data sets, and also linked big data in different ways to actually present this social gradient of musculoskeletal disease. So when we're actually talking about this social gradient, we really need to say that it is observed in bones too. So next slide, please. So that's just what we're going to do. What have we done? What do we know now about the social gradient of musculoskeletal disorders? Thank you. Okay, so we have some large data sets that we've linked. Now, Helen spoke about data linkage. We have done this data linkage a few different ways. What it ultimately gives us is we're accessing big data sets out there in the Australian level, and also by linking them and joining them in certain ways, we have even bigger data sets. But she's right in saying that there are actually at the moment very disparate. They sit alone. So I'm going to focus on how I've used the ABS data and to link with these different factors. ABS data, we know they give us the CIFA values, the ARIA, the accessibility and remoteness index of Australia. So I'm not going to dwell too much on the ABS, but I will touch on it. And the data sets I've linked with is the longitudinal GOS data set, patient records, so hospital records, a comprehensive fracture grid, and also a national registry. So if we just go on to the next slide. Briefly, we know that census is held every 5 years. We give individual level data, but the ABS actually aggregates it into indexes, aggregate levels. That's the CIFA that Helen spoke of. It's strong data, even though it's self-reported, but it's basically everybody. We can argue that it does encompass everybody or not. We can have a good debate about that. And as I mentioned, that ARIA index. So we get a lot of information from the ABS. Next one, thank you. This is where it gets interesting. If we use epidemiological data, which is population-based data, we actually get a lot more value out of linking with big data sets at the Australian level. So the Geelong Osteoporosis study is one of them. This is a longitudinal cohort, so it was first established in 93-94. It encompasses a full defined geographic area, and David Ashbridge talked about the importance of that this morning too. The GOS study randomly recruited a population-based age stratified sample, and they have at the moment 2 cohorts, a male and female, about 3,000 at baseline for both of those combined. So the importance of being randomly recruited is that it can be representative of the population. And this cohort has actually been linked with Medicare Australia data, national death indexes, again, big data sets, strong data sets. If the data is in these data sets, it's a given. So this cohort, the epidemiological cohort, it follows a group of people over time. So we've got basically 20 years of data, or up to 20 years of data, lifestyle, demographics, disease, all those sort of different measures that you actually don't get from big data sets. So the benefit of linking this, an epi study, with big data sets gives us so much more information. So next slide, thank you. This is the patient administrative data set that I was talking about, the Geelong Bone Densitometry Service. So we've used data from there. This encompasses one major service provider, meaning anybody who has a DEXA or a bone density scan shown there, they actually are in this data set. So it's comprehensive. Of course, if you're going for a bone density scan, you're referred, so you have a Medicare item number there. And the next data set, slide, thanks, is the GOS fracture grid associated with the Geelong Osteoporosis study, but keep in mind it's a different data set. This is a comprehensive, relatively comprehensive fracture register for that defined BSD region, the Barnes Statistical Division. It employed computerised keyword searches and it's cross-referenced with radiological reports. So it's very strong data. Everybody who had a fracture in the BSD, from 0 up to however long you want to live, is actually in this data set, this register. So it's quite strong. Now you can already see the level of value. They're not quite linked just yet. So next one. This is the final data set that I wanted to talk about. This is a national registry. This was set up for public and private hospitals across Australia to give information about joint replacements. It started with the knee and the hip, then it went on to include the shoulder, now includes other stuff. But it wanted to look at outcomes following joint replacement. So it's a really strong registry, and it actually has 99% completeness because they do cross-reference with a few different, I've listed them there, which is good, government separation data, health department unit record, and they use really complex matching to check it. So let's move on. So what does this do? Next slide, thank you, beautiful. So these are some of the results. These, I'm going to tell you which data sets we actually linked up to give this information, but I want to, before I go on to this, highlight the difficulties in linking. Ethical approval, you can link from your EPI data set to, say, the registry, but you can only link the people you have in your EPI data set to that registry, or you can get information from registries and out, but you don't know who they are. There's different ways to link. Canada is another country that does it well. Helen listed a few countries. Canada has population-wide or province-wide data sets, administrative data sets of everything you think of. Welfare, medical appointments, medication, everything is actually in one data set. We have to do it a little bit harder here at the moment. So by linking the GOS EPI cohort with the ABS CIFA data, we found this, that lower SES is associated with lifestyles known to increase the risk of the musculoskeletal disorders. It's not too surprising. We've got the weight is higher in the most disadvantaged, waist circumference, smoking status, etc. But that gives us an idea that the risk factors for disease are actually higher if you're disadvantaged compared to not. Next slide. We also found that differences exist in the fracture rates across the SES continuum. So as Helen was saying, a lot of these diseases and childhood factors and mortality, there is a social gradient. We see it in musculoskeletal disorders. On the left here, we have the hip fracture incidence. Oh, have you been saying finish a lot? I'm so sorry, I thought this was really cool. Okay, I'll just whip through. So we see that. Next slide, thank you. Next thing, throw something at me. We'll just skip through that too. Policy changes, just quickly. Medicare Australia in 2007 introduced changes to Medicare reimbursement for DEXA. It actually didn't have much impact. So we looked at uptake on DEXA before and after, didn't really change it. Disappointing, we need to do more. Next slide, please. Again, this is joint replacement. There's that social gradient. Next slide, thank you. What does all this mean? Okay, next slide. It means that important clinical implications. I'm so sorry I went over time. Thank you.